get started, thank you for coming. Ann Hyre is here to talk to us about maternal mortality in Indonesia. We're going to uncover the mystery of why it's not declining. Ann is
frustrations of why it's not declining.
Ann is a senior technical advisor for JAPIGO, which is an affiliate of Johns Hopkins University. She spent extensive time in Indonesia, was based there for 14 years. And we look forward to hearing about her work there, as well as maybe some of the other places she's been. Thanks, Ann.
Thanks. It's great to see some people. A few minutes ago, I thought, I wonder if anybody's actually going to come.
And these are many of our midwifery students.
Oh, is that right? Awesome. Great. Your whole class is coming.
A minute ago, so people were like,
Oh, I should have put a few. I have a couple of sample cases, and I thought, I don't know who the audience is going to be, but that'll be good because you guys are right. You'll get the message. So, thanks everybody, and welcome. This is my first time speaking here, so I'm excited. As Molly,
have you back, so.
What was that?
We'll have you back.
Yeah. So as Molly said, I just fairly recently relocated from Indonesia. I was there for 14 years, but I grew up here in Denver and sitting in the traffic and the air pollution of Jakarta. Has anybody here been to Indonesia?
Yes.
You have. Have you been to Jakarta?
No, I was in Surabaya.
Okay, well, kind of. There's quite a bit of traffic and congestion there as well. So, anyway, it's just been a real pleasure to be back in Denver, actually, and out of that. But I just wanted to, share some information about Indonesia and some of the work that I had been doing there. And let's see if I can turn this. So, before getting into Indonesia, though, especially since a lot of you are midwifery students, can anybody answer this question? What proportion or percentage of maternal deaths globally occur in developing countries? Any guesses? I hear a 50. Anybody else? 80. 80. You're getting closer. So, actually, 99% of maternal deaths actually occur in developing countries. A death here in the U.S. and Europe, places in Asia like Singapore are actually incredibly rare, but in developing countries, they are not so rare at all. And maternal mortality is the global health indicator that has the largest disparity between developed and developing countries. So what we do know, with 99% of all deaths occurring in developing countries, clearly, many countries have figured out how to prevent maternal death. So it's definitely something that is very preventable. So there's been a lot of attention. I don't know how many of you have followed a little bit in the past 10 years or so. There's been quite a bit of attention drawn now to maternal health because of the Millennium Development Goals. Sometimes I tend to be a little bit cautious about some of these goals, but in this particular case, I think that the establishment of these MDG goals, which ran from 2000 to 2015, definitely did draw a lot of attention to maternal mortality. And then now, as of 2016 up to 2030, the global, the UN General Assembly has agreed to new Sustainable Development Goals, or SDGs, as they're referring to. And maternal health is one of those in there, but there are 17 goals. For the MDGs, there were 8. Maternal health was one of them. Now there are 17, and maternal health is a part of them. But it is still definitely keeping up momentum or attention on maternal mortality, as well as newborn mortality, since we have someone here, one of the pediatricians. So there has been, the good news is there actually has been a lot of progress made. You may have seen that in the past couple of years, a lot of articles and news about the reductions in maternal mortality. So some countries have really seen significant declines, which has then led globally to a maternal mortality ratio from 1990 of 385 now down to 216. So that's been, in 15 years, that was a 44% reduction, which was definitely significant, though the MDG target was a 75% reduction, which was very ambitious, but at least it definitely directed a lot of attention to this particular problem. So these new Sustainable Development Goals, or SDGs, they have established a new target, which is a global maternal mortality ratio of 70. And then the part of this actually that I kind of like is that they do say that no country should be over 140. So I think as countries kind of tick this off and fall below 140, hopefully more and more attention will then be focused or targeted on those countries that are still higher than that number. All right, so that was just a brief background on maternal mortality. I'm now going to move into Indonesia and what's been going on in Indonesia. I don't know, again, if any of you have followed, but we are banging our heads against the wall, have been for many years, to really understand why maternal mortality continues to be so high in a country like Indonesia. Earlier, you said you had been to Indonesia. Did anyone else who came in later? Has anybody else ever been to Indonesia? Asia, Thailand, Vietnam, others? So you will have a little bit of a sense. But does anyone know the answer to this question? Where does Indonesia rank globally in terms of the size of the country, population? Any guesses?
Population.
It's population. It is very densely populated. So believe it or not, Indonesia is the 4th largest country in the world, behind China, India, the US, and Indonesia, which is a surprise. And as a result, because it's about 95% Muslim, it's the largest Muslim country in the world as well. So it consists of 33, though I'm thinking today it might already be 34 provinces, over 500 districts that are spread out across 17,000 islands, 3 time zones, and with 250 million people, the most of which, there's over 100 million people just on the island of Java. So it is very, very tough to ever escape people when you're on the island of Java. It's very, very densely populated. Indonesia, though, has been absolutely booming. Since the fall of Suharto in 1998, new government established, a booming middle class, really growing very quickly. The economy has grown 5 to 6% yearly, basically since the year 2000, and it is now the 8th largest economy in the world. So when I look at other countries that fall below it, it's remarkable. Their economy is bigger than the UK, than France, than a lot of more developed countries. So it's definitely a booming place to be. Literacy is very, very high in Indonesia. Contraceptive prevalence is high. It's up in the 60s. It's been stagnant for some time, but the good news with the stagnation is that it actually hasn't gone down since a lot of assistance, foreign assistance, and other assistance for family planning and reproductive health has gone away, but it has maintained. Here I use the term antenatal care, but prenatal care is almost universal. Nearly 100% of women get not only 1 antenatal visit, but the recommended 4 antenatal visits. And there is definitely a growing trend toward skilled attendance at birth and facility-based births. So when I arrived in Indonesia in 2000, only about 40% of women were giving birth in the presence of a doctor or a midwife, and 60% of births were still happening at home, some of those with midwives, but still many with traditional birth attendants. Fast forward now to 2016, over 80% of women are giving birth in the presence of either a midwife or a doctor, and about, depending on where you are, but also about 60, I think the official is 63% of women are giving birth not only together with a midwife, but in a health facility. But in an island like Java, those numbers are much, much higher. So there's definitely been a trend toward facility births. Back in 2000, 45% of all deaths were attributed to postpartum hemorrhage at home. Fast forward now, the vast majority of deaths are now occurring in facilities, in hospitals, and the number 1 cause of death is now preeclampsia or eclampsia. So hypertension in pregnancy is the number 1 cause of death now in Indonesia. I'm glad to see so many midwives here, since I'm a midwife myself. There are over 200,000, at this point there are probably closer to 300,000 maybe midwives in Indonesia, huge numbers of midwives. There are about 3,500 OBGYNs, similar number of pediatricians, but then there are probably more like 2,000 anesthesiologists. There are some nurse anesthetists, but the numbers are actually quite low for those particular things. But when you look at this information, a booming economy, growing middle class, trend toward facility-based birth, all of these things, you would think that Indonesia would have a maternal mortality of 50, 60, something comparable to Thailand, Vietnam, Malaysia. And yet, you look at these death rates, and it's just completely, almost inconceivable. So the newborn mortality rate is 19 currently, but it's actually been 19 since the year 2000. Well, in 2000, it was 20. So it's come down a little bit, but it's been very stagnant. And currently in Indonesia, over 50% of deaths that occur in children under the age of 5 occur in the first month of life. So there's some work to be done there for newborns. And a lot of that is tied in also with this very high maternal mortality ratio. So just as a comparison, these are some other countries that are neighboring Indonesia. And this is where, if you compare these, this is 2011 data. Maternal mortality is always very challenging to count and calculate. You can read a lot of information about that. But in general, these are, as of 2011, Lancet analysis, these were the maternal mortality rates. So you can see that Indonesia is higher than India, higher than even Cambodia was at this point. And you look at other countries like Pakistan, Nepal, Bangladesh, others that have really been successful at bringing down their maternal mortality rate, and yet you look at the infrastructure and other things that are there, and we can't really understand what exactly is going on. How can Indonesia continue to have such a high maternal mortality rate? So as a result of that, and given the fact that Indonesia stands out so much amongst other countries in Southeast Asia as having this very high maternal and newborn mortality rates, USAID, is everybody here somewhat familiar with USAID? So it's part of the U.S. government. So the U.S. government has continued to want to invest in providing assistance to Indonesia in maternal and newborn mortality. So for the past 5 years, until I moved here recently, I was heading up this program called the IMAS program. IMAS actually means gold in the Indonesian language, but it stood for Expanding Maternal and Newborn Survival. It's a 5-year sort of typical $55 million USAID program. And the purpose of it was really to try to increase coverage of some key life-saving interventions. So since we have so many midwives here, I'll specify a little bit more. So what we were working on were basically the 3 major killers of moms and babies. So it was postpartum hemorrhage, preeclampsia, eclampsia, maternal sepsis, and on the newborn side, birth asphyxia, newborn sepsis, and prematurity or low birth weight were the things that we focused on. So we were trying to increase, there are some well-known, very well-established interventions to address those 6 major killers, and we were wanting to work to make sure that every woman or every mother or every baby who was experiencing those complications would get these key life-saving interventions. So we were trying to increase coverage by strengthening emergency obstetric and newborn care across 150 hospitals and 300 health centers, and then trying to also improve the referral process, or the referral process from those community health centers on up to the hospital, to try to ensure that moms and babies were getting to the hospital more efficiently and getting the care that they needed in those hospitals. But in Indonesia, this is what the situation is. So kind of keep that maternal mortality ratio on the back of your mind as you read this slide. So there have been at least 15 years of significant investment on the part of the government as well as various donors to try to improve maternal and newborn mortality in Indonesia and across the health system in general. So Indonesia, when you go there, you've seen what it's like. There's actually very good infrastructure. There are community health centers, there are hospitals, there are private midwife clinics, a booming and a thriving private sector in terms of private clinics and hospitals. There are many health workers, as we talked about, and people have been trained repeatedly, including by myself and JPIGO and other organizations who have done a lot of training. So people have been through the training. National standards, evidence-based national standards regarding the provision of care are there. They exist. So there's very good policies in place. Supplies and equipment are available pretty much everywhere, even in some of the more remote areas of Indonesia and Eastern Indonesia. There you clearly have less to work with and more geographic constraints, or it's maybe harder for people to access clinics. But in places like Java, Sumatra, others, it's almost unheard of that you don't have contraceptives available, oxytocin, magnesium sulfate, some of the major things, antibiotics, blood. Supplies and equipment are available. That's not the problem. There's a lot of political will, especially now, given that Indonesia is feeling quite embarrassed, you could say, that the president has to go to these meetings on MDGs and hear a lot of countries say, what is going on in your country? How can you possibly have a maternal mortality ratio and newborn mortality rates that are that high? So a lot of political will and tons of money. It's remarkable. We were working in 30 districts, and in these districts, some of which are fairly remote, we definitely had the leadership in the districts who were willing to commit money to try to improve maternal and newborn health care. So money's not the problem. Supplies and equipment aren't the problem. The human resources in terms of the quantity don't seem to be the problem. So what is the problem?
The women, are they not taking advantage of all this stuff? It's really fascinating.
Yeah, no, it is. And one of the reasons why I'm doing this is because I think Indonesia is a fairly fascinating case study for what we refer to as middle income countries. So there's lots of countries like the Philippines and countries that are entering middle income status in Africa and other places that I think can really learn from this Indonesia scenario, where there's a lot there, but things are just not functioning. The system is not functioning. So our focus in this EMOS program was, as I said, we were trying to increase coverage of life-saving interventions, but over the past 5 years, we've done almost no training. We've provided no supplies and equipment. We've not needed to do any of that because everything was already there. It wasn't an issue of did a midwife have the skills or knowledge. Numerous surveys and case studies and things we did demonstrated that. But they might have the knowledge, they might have the oxytocin, or they might have the magnesium sulfate. There's a guideline that says that they should give it, and they've been trained, but they are there in a health center, essentially by themselves, scared and not knowing how to, if I give this, what's going to happen if I give this drug. And so they just really were lacking a lot of confidence, and therefore just referring women onto the hospital. And I'll talk more about what was happening in the hospitals. So anyway, the systems are all there. And so what our focus was really to put, I should say the basics were all there. It was the systems that seemed to be lacking. So we have really focused on these 150 hospitals and 300 health centers to try to put what we refer to as clinical governance systems in place. So internal hospital and health center management, introducing things like the use of data. These are hospitals and health centers. They collect all this data all the time, but none of it's useful. What's the husband's name, the address, things like that. There's nothing that was significant or useful that would demonstrate whether they were actually providing the life-saving interventions that needed to be provided. So we did a lot of focus as well with the hospital and the health center leaders to get them to be a bit more demanding about data, to begin to try to infuse a culture of collecting more strategic data and using it and sitting down and discussing it and tracking trends. Things like case fatality rates. None of these facilities even knew what a case fatality rate really was. They weren't, nobody was tracking that. Infection rates, anything like that. So we tried to introduce the use of data. Also introduce some standards, performance standards, trying to standardize the clinical care, and then therefore help the staff, the midwives, often functioning without being able to reach an OBGYN, but having standards in place so that they knew what it was that they should be striving for. We did a lot of work on introducing emergency teams, just getting people to understand, okay, when an emergency comes in, we have a team. You play the red role, the yellow role, or the green role. If you're green, you put an IV in and you do this. If you're yellow, you communicate with the family. If you're the red team, you are the coordinator of the care. And just getting people to function as a team so that when an emergency came in, it wasn't, people wouldn't say, oh, well, that's not my job, it's her job, and it was just always a lot of confusion and stress around emergencies coming in, both at the health center and the hospital. So just simple things like doing emergency drills on a regular basis and getting people to practice their communication and their teamwork. So these were some of the types of things that we did. We also introduced audits, and the women were dying in hospitals, and nobody was ever auditing what happened. There was never a discussion. People would fill out a piece of paper, but teams of midwives and doctors never sat down and said, we had a woman die, let's think about and look at, what happened and review the case together. So death audits, near-miss audits, those were all new concepts. So the program supported the development of this. And as I'm talking up here, I'm saying we, and you might be thinking we was me. We had nothing to do with myself or Japaigo. We were really lucky in Indonesia that there's a remarkable private maternity hospital there called the Budi Kemuliaan Hospital that does about 8,000 births per year. But they have an incredible leader, a very charismatic guy who is an early adopter of many, many things. So they are a real model for both clinical practices and perhaps more importantly, their clinical governance or the systems that they have in place that ensure that the standard of care is always high, and that individuals who work within that hospital are held accountable for the quality of the care that they're providing. So we used them to mentor. So that hospital initially mentored 23 hospitals. We had people going back and forth over about 2 years. They would go to the hospital would come to them to try to introduce these things. How do you do an audit? How do you do an emergency drill? How do you use data? Things like that. And then those 23 hospitals got up to the level of where they could then mentor others, and that's how we eventually reached our USA target of 150 hospitals. So we were also working on the referral strengthening, and the purpose of what we were doing in referrals was to try to improve communication between the health center and the hospital. So very often there was no communication. The hospital never would know when a woman was coming. Also, the health center wouldn't know if that hospital could even accept the woman. And so you had a lot of multiple referrals, women going from one hospital to another, before they ultimately got to the place to get the care that they would need. There was also, as I was saying earlier, these health center staff don't necessarily have the confidence to be able to stabilize or manage a complication that happens at the health center. And so we wanted to open up mechanisms by which they could consult with staff at the hospital before referring. So we introduced an SMS-based and a call center-based technology that would enable health center staff to not only notify the hospital, but also for that hospital then say, okay, before you refer her, do this and this and this and this. And that simply boosted the confidence often of the midwives to actually take the action they needed to do prior to referring her on to the hospital. So that was a lot of the focus on the referral system. So, did any of this do anything? This is the frustrating part. So, I don't know how well you guys can see this, but what this tracks is, so we are tracking currently, the program actually ends in December of this year, but believe it or not, we have been tracking approximately 170,000 births each year. So we introduced into the hospital some more strategic data so that they could see, okay, of these women, the assumption was, oh, of course they're getting oxytocin. The drugs are there, people have been trained, the national guidelines and policies are there. Of course women are getting oxytocin, or of course babies are being put to breast, immediately after birth. Of course these things are happening. Well, when it came to it, and we actually introduced a log that people could track these things, the numbers were actually quite low for a number of things. So what this tracks is the numbers of cases who needed magnesium sulfate to prevent seizures in hospitals, the numbers of women who received oxytocin for the third stage of labor, so after the baby was born, before the placenta is delivered, giving oxytocin, which has been shown to reduce the occurrence of postpartum hemorrhage. And the lower one here shows the coverage of the provision of magnesium sulfate at a health center prior to a woman being referred. So these were three kind of sentinel statistics or indicators that we were tracking. So actually, before we started, you can somewhat see here. So women, the oxytocin, the provision of oxytocin for active management of third stage of labor has been quite high. When we started, it was already 88%, and pretty much now it's gone to 100%. And we do have some good data that has shown that the incidence of postpartum hemorrhage has actually decreased. So that's an encouraging thing. Magnesium sulfate was a little bit all over the place, was at 92, and then as we introduced better data systems, it became clear that, in fact, not that high, and now it's also very high, 99, 100%. Where we've seen the most amount of progress, or the most significant progress, has been the numbers of women who are receiving magnesium sulfate at the health center prior to being referred. And that, we were only at 11%, 22% at the baseline, and now it's gone up. It went up from 22 to about 60%, and then from 11% to now 44%. So that looks like good progress until you think, okay, so 44% of women who need this drug, a life-saving cheap drug that is available at the health center, that means that, 36% or so of women who need that are not getting it. So they're arriving at the hospital not having yet been stabilized and are possibly then in a worse condition than had the health center given it. So even though we see that there has been some progress, often I still say, well, we can't, be applauding this. There's still 40% of women who need a drug that's available that are not receiving this. On the newborn side, we were tracking early initiation of breastfeeding, so being put to breast and breastfeeding in the first hour after birth. And that, again, this is one of the ones that was really just, really drives me crazy. Because initially the baseline was 49%. So again, you don't even require, nothing is really required to put the baby on somebody's breast. And this has been a national policy since the year 2000 in Indonesia. And yet our baseline showed that only 40-something% of babies were actually being put to breast. So now it's up into the high 70s. So there is progress there. Antenatal corticosteroids. So giving a baby or giving the mother dexamethasone, in the case of Indonesia, dexamethasone, when it looks like she may be delivering prematurely in order to help mature the lungs of the baby, antenatal corticosteroids were almost not given at all. It was 18%, and that has gone way up to about 80%. So there has been, that's the one indicator that I think we actually feel really good about, that more babies are now getting antenatal corticosteroids before birth. And then giving antibiotics at the health center prior to referral. This is one that we've really struggled to make any progress on. Baseline was 13%. We're now in the 20s. But again, it's not that the antibiotic is not at the health center. There's a national policy that says the health center should give the antibiotic. Midwives have been trained to give the antibiotic, but they're not giving it because they're either fearful that they're going to be scolded by the pediatrician if they do something like that, and maybe they feel that they can't do it. Or there are many, many newborns. What we found looking very carefully at this indicator, we did a whole special study around this one because we were not making any progress. It turns out that most families, when their newborn is sick, they bring the baby to the private midwife clinic that is near their community. So there are private midwife clinics all over Indonesia, very well distributed. So people tend to go there as opposed to taking them to the government community health center. Unfortunately, those private midwife clinics, there is a law that says that they are not allowed to store antibiotics in their clinic. And so they raise this all the time, and people have fought to try to change this. But again, the midwife has the knowledge. She actually could provide the antibiotic, but she's prevented because of a policy in this particular case. And so this is where we as a program would try to really go and raise this at higher levels and advocate that this is what's going on. So a bit frustrating. We did manage to see significant increases in the numbers of deaths that were audited. feels like a success, I guess, as grim as that sounds. But at least now we're seeing much higher percentage. We are seeing that for the first time, really. Many facilities are sitting down when a death occurs, that within 24 to 48 hours, a team is sitting down and discussing actually what happens. So through all of this, and feeling good and seeing lots of very good, tangible progress in these hospitals that were mentored by the hospital I mentioned earlier, we have still continued to be very frustrated at the fact that deaths are still not coming down. If you look at the absolute numbers of deaths that are occurring in the hospitals and the health centers and the districts where we're working, yeah, there are some. Some have had shown decreases. And it is tough because when let's say you have 2 deaths one year and you have 4 deaths the next year, it's still not a huge number, and yet it looks like a 50% increase, or vice versa. We might have had 4 deaths one year, the next year there's only 2. It's easy to get excited about, a 50% decrease, and yet those numbers, 1 or 2 deaths can really sway the numbers a lot, which is why we tried to, instead of, we ended up tracking institutional mortality rates versus case fatality rates, because there was just too much, it was too dependent on the clinician's ability to make a good diagnosis to determine a case fatality rate. So the institutional mortality rate, we are simply taking the numbers of deaths divided by the numbers of births. And we have seen some decreases, but if you look across the districts, the 30 districts, yeah, there were districts that saw fewer deaths, that have been where the death rates are coming down. But in general, not to the extent that we would want. So once again, pounding our heads against the wall, we said we need to take a closer look at what is really going on. So even though we've introduced audits, we were feeling like the objectivity of that audit was really not very high, because in districts where you might only have 1 or 2 OBGYNs or pediatricians or anesthesiologists, they're the ones who are reviewing their own case in front of their peers, basically, and it's very tough for them to really be objective about what happens. We also know that the quality of an audit is really only as good as the quality of the documentation or the recording of what happened. And when you get a chart that's basically blank, there's not much you can do. So we're happy that more and more facilities are starting to think about data and use data and are starting to think about and do audits, though we know that the quality of those audits is not ideal. So we wanted to really look more at, just take a little bit closer look. So we decided to do an external review of charts of mothers who had died in the hospitals that we had been working with. We used a phased approach. Sorry, I forgot to mention that earlier. So we initially started with 23 hospitals, and then we expanded to 75 hospitals, and then to 150. So the phase 1 were these 23 hospitals that we first worked with, where we had the most amount of time there. So of those 23 hospitals, we selected 12 hospitals and said, we're going to go and just look at the chart, see what we can find out about what happened in those deaths that occurred. We just really wanted to get a better sense of what were some of the things that contributed to those deaths. We did not know at all going in. This was not at all an academic, rigorous, IRB-approved study that we did. The hospitals were willing to let us do this, and we went and just looked at the charts, but really not knowing, first of all, would the hospital give us access, which they did, and then second of all, what would we find in these charts? Would there be anything that would be useful, that would enable us to try to pinpoint some of what was going on? But we did get access. We reviewed charts, and for each one, as we looked at the chart, and this was a team of some of our staff, they looked at the chart and did a little case synopsis for each of reading the chart, they developed kind of what was the progression, what happened from the time she arrived at the hospital until she died. They did a little synopsis and reviewed it and made some determinations about what were the major contributing factors. Those synopses were then reviewed by a group of 24 OBGYNs who we gathered in Jakarta. They went through all those cases and either validated or disputed what the group of midwives and doctors had determined when they first read the charts. So there was an analysis of all of these cases. So since we've got midwives in the room, I'm glad I included some of these. I was thinking maybe I would skip over them. But let me just walk you through one of, so we ended up doing 112. There was enough data on 112 deaths across 12 different hospitals. And I've just included a couple here. So in this case, this was a 31-year-old woman in her first pregnancy. She was 39 weeks pregnant. She was referred to a hospital, referred from the health center to the hospital with very high blood pressure. When she arrived at the hospital, her blood pressure was 187/120, which is very high. She was drowsy, she didn't have a fever, and her fetal heart rate was between 60 and 100. So normal would have been closer to 110 to 140 perhaps. So fetal heart rate was lower than it should have been. So the first OBGYN could not be reached when they first, this is already in the hospital. The first OBGYN couldn't be reached. They then contacted a second OBGYN by phone who advised that this woman should be put in the intensive care unit at the hospital. And this was Saturday at midnight. So on Sunday, the fetal heart rate had come down even less. It was now at 70. The C-section was still delayed because of wanting her condition to be more stable. And by now, she was starting to have a fever. These are Celsius. Sorry, I didn't change those. So on Monday, she then started to develop a fever. She finally, although she came in Saturday at midnight, on Tuesday, she finally had a C-section. The status of the baby we actually don't know because none of this was documented in the chart. The mother spiked a fever and then died 2 days later after having a C-section.
And is it worth assuming the baby died too?
Assuming, but not, yes. I mean, if you look at how this whole thing progressed, yes, most likely it did. And remembering that the real cure to severe preeclampsia is delivery of the baby. Their national guideline says that it should have been delivered, immediately upon arriving at the hospital.
So, like, with all this data analysis and review, it's really just, like, the problems in the education of the OBs and the midwives?
That, unfortunately, that seems to be a lot of what it was. Yes?
Who pays? Are patients paying as they show up at the hospital? Are the families paying, or is the government paying for hospital visits and stays?
In these hospitals, actually, Indonesia is, in 2014, rolled out universal health coverage. But in 2011, they actually had the equivalent of universal health coverage for childbirth, for antenatal care, childbirth, postpartum care, and family planning. So in most of these government district hospitals where nearly every complication is referred to, according to the data we've been tracking, it's about 80-85% are being covered by the social insurance. Some of them are having to pay out of pocket. But what we have not been able to really see a clear linkage between finances being a barrier to what was. So we looked at whether finances contributed to these deaths. Was that in fact a contributing factor? But it didn't appear to be, given what we could at least determine in the chart and just kind of hearsay and anecdotes and spending time in these hospitals. So interestingly, financial barriers don't seem to be the major issue. This is another kind of very similar case. So it's somebody who actually gets to the hospital in a condition where she should survive, but because of what is happening in the hospital, delayed decision-making, multiple delays, incorrect decision-making, incorrect diagnoses, the patient actually dies. So what we learned was basically this, and this was just startling information and very, very demoralizing for our partner hospital, Budi Kemuliaan, who had spent several years where their entire institution was totally devoted to mentoring and helping these other hospitals. For them to see this, a bunch of OBGYNs, was just devastating. So 70% of the cases, the OBGYN was either not present or very delayed in coming. The clinical management, for me, it's the second bullet that's the hardest. So even when an OBGYN was present, perhaps, the clinical decision-making and the diagnosis was incorrect in over 50% of the cases. So your question about education, suddenly it's like, wow, the ability, the complexity of these cases is definitely exceeding the capacity of the specialists to manage this. Part of me wonders, well, it wasn't that long ago that women were almost always dying at home, and now these cases are coming to the hospital. They're quite complex. There are not huge numbers of specialists, either OBGYNs, pediatricians, or anesthesiologists, and so is this now exceeding the capacity of those who are working there to manage? There were still, in most cases, not in most cases, there were still, across the cases, about 30% of women who you could tell had been delayed in some way along the referral pathway. They either sought care too late, or there was a delay from the health center in referring her and her actually arriving in that hospital. But when I see this is what I keep saying to the Ministry of Health and others, this means that 70% of women, the family did the right thing. It wasn't the family's fault. It wasn't the village midwife's fault. It wasn't the community health center who messed up. All these things we're always hearing. All the blame is always going that way. These people arrived at the hospital and should have survived and did not because of what happened in the hospital. 70% of these cases. And these OBGYNs who reviewed these felt that in 72% of the cases, the women should have survived. And had they arrived at this Budi Kemuliaan hospital in Jakarta, probably another 24% would have survived had they gotten the care that they want. So, you have a question before I go on?
So were cultural factors considered in this review?
I can't say that they were, probably. We just looked at every death that had occurred at the hospital. So regardless of socioeconomic status, regardless of anything, we just read the medical chart. And as I said, this was a quick and dirty. We basically, from the time we decided to do this, 6 weeks later, we had all this data. So we just said, we've got to understand what is going on, because clearly what we're doing is not having the impact that we need. And people, USAID and the Ministry of Health, had these huge expectations for great decreases in maternal mortality based on what we were seeing, the progress we were seeing. And so we said, let's just dive in and do this quick and dirty sort of look at charts and see what we find out. And we were pretty stunned. I was in tears. I kid you not, sitting at my desk reading 112 cases like the two that we just saw, seeing their ages, seeing their cases, oh my God, it was awful. I was just in tears reading these things out of just frustration and anger when I would see this kind of stuff, that these decisions were just not being made.
I'm curious if you meant the culture of the patients or the culture of the providers in the medical community. Because I've been thinking, you first asked about education of the providers, and I'm curious if the culture of the providers and the culture of the medical care, more so than their local culture, is part of what you saw as the problem. And I guess maybe you'll get to this in a minute, but is your next step to look at the curriculum of these providers and try to understand where these issues are arising, if it's during their training or, again, part of the medical culture in the facilities?
Mm-hmm. Yeah, I am going to get to that in terms of what some different approaches might be, but it's part of, granted, I'm very biased in my opinions, but from what one of the major issues I see in Indonesia is that very few people speak English. So even specialists are not very strong in English. And if you look at global literature, there is almost no Indonesian literature. In fact, Richard Horton, the editor of The Lancet, if you read back about 6 months ago, he wrote this great commentary about where is Indonesia. It's nowhere. He looks back at all the Lancet editions from the past, And it was this hilarious thing about there had been like 2,000 articles on the U.S. and, many thousands on China and India, and that Indonesia had been mentioned in the Lancet like 8 times or something. It was crazy. And so OBGYNs, from what I can tell there, they're very busy, and in their education system, they're tending to use, just old sort of outdated textbooks. Very rarely are they actually accessing the medical literature because they can't read it, since most of it's in English. They're not publishing anything. And it's just, Indonesia has become increasingly, in the 14, 15 years I was there, has become increasingly insular. There's very little interest in sort of looking outside of their borders to say, well, what's happened in Vietnam and Thailand and Malaysia and Singapore? What can we learn from those other countries? What do we need to learn? People are they just kind of stay kind of looking inward. And so I really think that language, that may sound like kind of a cop-out, but I think that language is actually playing a big role in why the medical education is not progressing as it should, and why I think a lot of these practices and things are quite outdated. There is culturally as well the hierarchy with the senior specialists versus the younger, junior level. It's always the senior one. They are always the ones who are right. And so even if a more junior person is questioning the clinical practice of a more senior person, they wouldn't publicly question that, and they would just kind of go along with what that person is saying, which is where, through all this clinical governance work we try to do, we're trying to infuse kind of more accountability. That if you're seeing something that somebody is doing that is wrong, you are accountable for that. And it's not okay to do nothing. In Indonesia, doing nothing is very accepted. It's perfectly fine for a midwife who's got magnesium sulfate or who's got newborn antibiotics to refer somebody without doing anything. She's never held accountable for that. Nobody is, I kept trying to say she should be, held accountable for doing something. That should be what people are focused on. It's not, so she's afraid that she's going to be punished if she takes action. I've been saying it needs to be the opposite. Not taking action is not okay. This person, whoever it is, needs to be taking action. But so culturally, there definitely are those aspects. So based on what we found, and we were like, oh my gosh, if we were able in these chart reviews to come up with this information about maternal deaths, let's repeat the same thing for newborns. And the findings were very, very similar, which surprised us. We thought that, we just weren't expecting. So pediatricians in Indonesia, they have about a 3-month focus on newborn care during their basic medical education. So there are only about 100 neonatologists in the whole country. So there aren't many people. There are many pediatricians who are responsible for caring for newborns who really don't feel that they've ever been properly trained or that they really have the expertise. And so as a result, I think we see a lot of the same thing: incorrect diagnoses, improper management, starving babies, frankly, babies who are just not getting the caloric intake that they need these are sick newborns. And again, similar to OBGYNs, 55% of the newborns we ended up with 76 cases that we felt we had enough information about. So in 76 of the 76 cases, and 55% of them died without ever having been physically examined by a pediatrician. So very similar findings with the OBGYNs. So then, once we've had this data, I'm just going to wrap up here with a few things. It's been challenging, very hard for the OBGYN and the pediatrics associations who did these 2 reviews to figure out what do we do with this data. The OBGYNs definitely did not want this kind of getting out, and we really went back and forth trying to encourage them. You can't be fearful of this information. You've got to act on it. And anyway, finally, they've started to be a bit more public about some of the findings. The pediatricians, I think, the neonatologists were somehow more comfortable getting the data out, sharing it with the Ministry of Health, getting it into the media, things like that. I think maybe because they knew it was pediatricians and not neonatologists who were coming up here as the ones who weren't present. I'm not sure what it was, but they were definitely more open with the information. But it's been a struggle for us because we wanted to get it out, and yet there's so many sensitivities because this was pretty striking information. But what I think, so one take-home message for me and what I've been trying is we've tried to present some of this data in some other global conferences, is that I don't think we would have come up with this had we not, we wouldn't have come up with this information had we not sat down and looked at these charts. And yet so many investments and what people focus on is always, it's the community interventions, and it's the, we need more training, we need more this, we need more that, with a lot of assumptions that the families aren't making the right decisions, that the community health workers aren't doing the right things, that the community health centers are not doing the right thing, that referral is terrible. There's always those assumptions. Very rarely, even in Indonesia, even with me there for 2 years talking about this constantly, there is still, you just don't sit in meetings and hear people say, oh, the problem is the hospital. And so this, at least, as I said, we spent almost no money to do this, and it only took us 6 weeks in both cases for the mothers and the newborns, and yet this is now giving us the information that we can say, you know what? It's not the mother, and it's not the midwife in the community, it's not the community health center, it's the hospital. This is where, in countries where more and more women are giving birth in hospitals, this is actually now in Indonesia where we're seeing the majority of the problems happening. So now we at least have something to use. And so I've been trying to encourage other JPIGO programs in other countries who are, struggling with these same things, like go and spend some time and look at some of the charts and try to get a better sense of what exactly is going on in these deaths and see if it can answer any questions. So some of the future directions for Indonesia, to not leave everybody feeling like, no. I apologize for that. This really just drives me crazy. So if you look now in some of the global literature, you will start to see in some of the WHO and other articles and things that now people are coming out and saying, okay, we've come this far in maternal mortality, but to get from a 300 MMR down to a 150 MMR requires very different investments than it does to go now from 150 to 50, for instance. And what we are seeing is that it really comes down to a lot of quality of care. It's no longer access. In much of Indonesia, it's no longer access that's the problem. It's really what we can see. It's quality. It's what's happening once they're arriving in the hospital. So more significant investment in secondary and tertiary care. And again, in the literature globally, you're now seeing more of this as well. And so this is something that we continue to try to advocate for in Indonesia, even though we did focus on secondary and tertiary care, and have seen some progress, but not what we want. So I think some of these other things that I've been saying in Indonesia, we actually just 2 weeks ago, we did a hackathon where we tried to get some different stakeholders around the table, and we presented this data. And so, does anybody have any good ideas? They didn't necessarily come up with anything new and exciting, but something that is clear is there's a lot of financial disincentives for the OBGYNs, the pediatricians, and the anesthesiologists to be providing care in the places where mothers are being referred to for complications. So when the OBGYNs are not there, they're all off in their private practice, even though they are government employees and supposed to be present in that hospital. And when a complication occurs at the private hospital, they actually refer her still to the government hospital, because if a death's going to occur, they don't want it to occur in their private hospital. And then they may go and provide the care in the government hospital. But for the most part, you can easily, I've actually said, well, what we need is like a drone or a GPS tracker. We need to know at all times where these OBGYNs are, so that if it occurs, if there's a complication, she can go to where they are. But anyway, I think that there does need to be some better. India and some other countries have some good examples of where they have changed their payment schemes and things in order to encourage or in order to enable OBGYNs and pediatricians to spend more time in the government hospital than just in their private practice. And then you were asking about education. I have come to the point, so most of the work that I did early on in Indonesia was around midwifery education and working and strengthening the schools there. And I definitely got to a point, and I sort of am at this point now with medical education in Indonesia, that, I am tired of investing in the faculty and improving teaching skills and trying to improve education. I almost want to just leap over that through some technology, do away with that whole having to deal with outdated, faculty and others, and try to do something else. And in this case, I feel like instead of investing in improving some of these education systems, I'm almost more inclined to set up some good systems for some remote consultation, so that when an OBGYN, getting them to the point where they recognize that, oh, I really don't know what to do in this case, and that they actually then have some formal mechanism by which they can reach out to somebody and consult by telephone or by video or whatever it is to get the information that they need. I feel like we might make more progress trying to do something like that for the pediatricians, the midwives, the OBGYNs, setting some mechanisms in place, recognizing that the medical education does need to improve, and that's a long-term sort of sustained investment that needs to happen. But in the meantime, is there a possibility for some more remote consultation or something like that, which would get people making better clinical decisions? So, a few ideas. Question?
You mentioned kind of just the text messaging as far as like stabilization procedures of that. Were you able to track just like specifically those case mortality for those particular instances where the midwives at the district level were actually able to employ those stabilization techniques? Was there better survival, or was that not kind of delineated?
So we are in the process of doing a very rigorous program evaluation for a number of elements, and one of them is around that ICT innovation that was introduced to track that. So we do have lots of, the system itself mines a lot of data around diagnoses and the time she goes from the health center, what time does she get to the hospital, things like that. And so we have, for these cases, we do know if they were referred or not using that system. And I think, as I recall, is it about 60% of the cases they had used the system. But and so then that brings up, well, gosh, what what does that mean? They seem to be arriving in pretty good condition at the hospital, but then that seems to be where things begin to deteriorate, is once she's actually there. So that referral, the improved referral process, doesn't seem to be having the impact that we would want.
I have a friend that was a nurse in a Muslim-dominated country, and she expressed a lot of frustration around inaction and how it affected patients.
Mm-hmm.
And she described one case where her patient died on the OR table. It was a hemorrhage. And the physician needed the FOC's approval to do a hysterectomy. Mm-hmm. And then there was a lot of discussion about the pros and the cons. And then prayer happened, mm-hmm. and so they all prayed. And all of those things took precedence. Mm-hmm. And maybe that's the wrong way to say it. They felt that those things were just as important, even though the patient was bleeding to death. Yeah. And so she died.
It sounds very similar to a lot of what we're seeing here. And as I was saying, inaction is very acceptable.
And, in reading that book, 3 Cups of Tea, it came out like forever ago.
Yep.
It talked about that sort of the culture needing a lot of time to think and
mm-hmm.
discuss.
Yep. Deliberate. Right. Yep. And that's what we found, and that's where these OBGYNs were also very frustrated. It's like, since when does the anesthesiologist make the decision on an obstetric patient? That's totally unacceptable. And so that's where they were expressing a lot of frustrations with that. But definitely in Indonesia, particularly more so, I would say, not more so, but for newborns, for both. For newborns and mothers, there's a lot of, it's Allah's way, it's God's way. And so there is a lot of sort of just resignation that, this is just the way it is. And as I said, people are, I see it even more so with babies. People are not fighting or not complaining or arguing when babies, it's not getting much attention when babies die. At least now when moms die, we're seeing more and more anger, perhaps, or more questioning about it. But still, there's still a lot of acceptance of the problem.
Anger, is that coming from like the medical community? Because we talked about that one hospital, or is it coming from like the locals themselves saying, "Hey, you're killing our women, yep. You're killing our babies." We're seeing like the most, I guess, frustrations. And I think that if communities were saying, "Hey, it's not fair that our babies are dying while our neighbors' babies are not," that might kind of move change.
Yep. And on one of the slides I showed about what we were doing in Referral, there was something that referred to these civic forums. And so, yes, we used a very large faith-based organization called Muhammadiyah in Indonesia that has 40 million members around the country to try to do exactly what you're saying. So when a death occurred, we wanted them to be basically like the complainer, the watchdog, whatever, to basically make sure, well, what happened with that death? Is something being done? Was action being taken? Was it audited? Trying to get more and more people unhappy. And Facebook, Indonesia used to be the number 2 Facebook user in the world. It may still be behind the US. So Facebook and Twitter are huge in Indonesia. And that has actually helped to generate more and more demand for answers or solutions. So
it's a little bit after 1.
Yes, sorry.
Yeah. Conflicts. Okay. If you're willing to stay, maybe people could stay and ask a few more questions.
Yeah, sure. If you guys have a couple more questions. Yeah.
Thanks.